Hello everyone, my name is Shivangi and I'm presenting my research on the factors associated with telemedicine usage and acceptance pre and since COVID-19. Before diving into more, I want to make sure everyone's on the same page as to what telemedicine is. This research focused on this definition provided by the Centers for Medicare and Medicaid Services, who say that telemedicine is the general use of technology which seeks to advance individuals' health by allowing real-time collaborative communication between a patient and a practitioner that may be physically distant. This topic became of great interest to me at the beginning of the COVID-19 pandemic, where I was shadowing healthcare professionals who had to quickly adapt to telemedicine. In fact, they aren't alone. Research now shows that healthcare practitioners are now seeing 50 to 175 times more patients through telemedicine now than they were before COVID-19. And it makes sense because telemedicine allows to care for quarantining patients, and it's been of great aid in lessening the impact of COVID-19 on the US healthcare system. So, in all of this, I saw how advantageous telemedicine could have been before the COVID-19 pandemic. I was shocked to find out before COVID-19, there were already telemedicine programs in each of the 50 states, mostly aimed towards rural and remote communities. Yet it's estimated only around 1% of people eligible to access those programs ever did before the pandemic. This extremely low percentage demonstrated an issue in the lack of telemedicine uptake that needed to be further investigated. It's clear that telemedicine needs to be properly integrated into our healthcare systems. Most of the studies I'd come across focused on telemedicine usage with healthcare providers, but not patients. And with the ongoing COVID-19 pandemic, many patients have been forced to adopt telemedicine the same way healthcare providers were. So, to overview my rationale so far, many proven benefits have been shown with telemedicine, including an increased access to healthcare. The COVID-19 pandemic acted as a catalyst for telemedicine uptake in the US for patients and healthcare practitioners. Telemedicine programs existed in the US with little uptake before the pandemic and without research saying why this was so. And the majority of telemedicine research taking place in the United States focused on healthcare professionals and not patients, creating gaps in the literature. Researching within the timeline of pre and since COVID-19 is also vital to understanding what main factors are integral for a generally higher patient uptake for future telemedicine programs. So firstly, it was important to address the barriers to accessing telemedicine. First off, there is actually no standardized legislation regarding how healthcare practitioners can exercise telemedicine. On that note, there are no federal telemedicine licensure laws, and this prevents healthcare providers from using telemedicine services across state lines. With the COVID-19 pandemic, these limitations have been relaxed, but it's uncertain how this will hold up in the future. Different insurance companies and government agencies are also divided in their telemedicine billing reimbursement policies. This has also been relaxed, but it's unsure if these changes are permanent or not. Lastly, almost all forms of telemedicine requires a stable internet connection, and in rural parts of the US, it's estimated that 1 in 4 individuals do not have access to a high-speed internet. So now to understand the factors associated with telemedicine usage and acceptance pre and since COVID-19, the theoretical foundation for the study was an integrated model of the theory of planned behavior, abbreviated as TPB, and the technology acceptance model, abbreviated as TAM. Both have been dominant theoretical models when investigating the factors affecting users' acceptance of novel technical systems such as telemedicine. The integrated model works cohesively because both models are derived from the same parent model. The constructs for each model are color-coded in the image above, and the ways in which they interact are also depicted through the arrows. So the integrated model aimed to facilitate the explanatory powers of both separate models. Based on everything I've said so far, my research aimed to answer the following two research questions. 1. What are the predictors of the use of telemedicine before the COVID-19 pandemic? And 2. What are the predictors of the use of telemedicine since the start of the COVID-19 pandemic? The overall sample included exactly 200 respondents who met the requirements of being 18 years of age or older and residing within the United States. IRB approval was attained for the survey and marketing materials as shown here, and the survey was then disseminated through social media, email, and snowball techniques. The survey instrument consisted of the following main sections. Most questions were asked twice in the context of pre and since COVID-19, with the exception being the demographics section. The study measured 3 independent variables and 2 dependent variables. The 3 independent variables were demographics, the integrated model questions, and the devices used to access telemedicine. The 2 dependent variables were telemedicine uptake pre and since COVID-19. All the analyses were conducted using SPSS version 27. Descriptive statistics were calculated to describe the population sample that was surveyed and to describe the uptake of telemedicine pre and since COVID-19. Some scores were calculated for the questions that were asked on the Likert type scale. Chi-square tests of independence were used to assess the relationships between the independent and the dependent variables, and the independent variables that were statistically significant with the uptake and acceptance of telemedicine pre and since COVID-19 were then included in the logistic regression model via a backwards entry. So, of the 200 participants, the major demographic characteristics are depicted here. 195 reported whether they'd accessed telemedicine before COVID-19. Of the 195, 117 reported that they had. 186 reported whether they'd accessed telemedicine since COVID-19, and of the 186, 111 reported that they had. Mobile phones were the devices used to access telemedicine the most, both pre and since COVID-19. So now to answer research question 1, rewritten here, it was found that racial and ethnic identity made a statistically significant contribution at a p-value less than 0.05, and it was the strongest predictor of telemedicine uptake before COVID-19. The variables depicted on the table were put into the logistic regression based on the results of the chi-square tests. The pre-COVID-19 model was statistically significant at a p-value less than 0.001, indicating that it could distinguish between respondents who had and had not used telemedicine before COVID-19. Overall, the model explained between 14.7% and 19.9% of the variance in taking up telemedicine before COVID-19. On to answering research question 2, the devices respondents used to access telemedicine made a statistically significant contribution at a p-value less than 0.05 and was the strongest predictor of telemedicine uptake since COVID-19. The since COVID-19 model was also statistically significant at a p-value less than 0.001, indicating the model could distinguish between respondents who had and had not reported using telemedicine since COVID-19. This model explained 24.9% to 33.9% of the variance in telemedicine uptake since COVID-19, greater than the pre-COVID-19 model. So with the prior results, the integrated model had a far greater explanatory powers under the high-stress, high-threat situation of the COVID-19 pandemic. The results are also consistent with the previous literature on the subject matter. Prior to COVID-19, it was already understood that underrepresented racial and ethnic groups had barriers to accessing telemedicine, such as awareness of telemedicine to begin with, and having sufficient internet access. Since COVID-19, it's been understood that the type of device people use to access telemedicine is impactful because it can affect the quality and diagnostic capabilities of a telemedicine appointment. Considering this study took place during COVID-19 and examined the factors affecting patient uptake, it is still unique in its type and contributes to the existing literature. So though my study was expansive, it still had a few limitations. For one, convenient sampling may not always be representative. Furthermore, the survey was only accessible in English as an online instrument due to the nature of the ongoing COVID-19 pandemic. Lastly, it was difficult to distinguish which healthcare providers people felt more comfortable seeing via telemedicine. Overall, to conclude, telemedicine has been an essential component in the U.S. healthcare response to COVID-19 by reducing strain and ensuring healthcare needs are being met for the general population. Despite this study having its limitations, the findings reveal that factors such as racial and ethnic identity and the devices used to access telemedicine were significant with the likelihood to uptake and accept telemedicine. Future research should focus more on examining the integrated model within various contexts, such as in rural communities, and potentially a paper option for the survey to make it more inclusive. Efforts towards increasing the uptake and acceptance of telemedicine in the future should focus on increasing the access to appropriate devices for telemedicine appointments to heighten the quality and diagnostic accuracy. Healthcare professionals and policymakers also must understand the difficulties that certain marginalized racial and ethnic communities face when it comes to accessing healthcare and telemedicine specifically for future policy and long-standing telemedicine implementation. So thank you so much for listening to my presentation. If there are any questions or comments, please feel free to comment on my presentation and I will be sure to reply. Thank you so much.